Good afternoon, good evening, and good morning, depending on your location around the globe. You are welcome to our next post Congress webinar. We are going to talk today about post ASH 2024 allogenic stem cell transplantation summary by Professor Nagler. Professor Nagler, let me tell you, good friend, mentor, and one of the great speaker, one of my best speaker, best person. If I have any question on transplantation, he's on my speed dial. One of the best person. He has published more than 1,000 paper in the field of stem cell transplantation and cellular therapy. So I'll give us a good review about all the allotransplantation section presented at the ASH meeting in December. Professor Nagler, floor is yours. Thank you again, sir.
Thank you very much, Professor Savani, for your kind words. I hope that I deserve them. And it's a real pleasure for me to present on behalf of the International Academy of Clinical Hematology a post-ASH 2024 series about allogeneic stem cell transplantation. Obviously, it ASH, and a lot is going on, so I upfront apologize for those studies I could not include it. So we will start with a spotlight session, making a match, optimal donor, HLA and beyond. And the first talk is by Professor Muhammad Moti, who is the pioneer and the chair of the International Academy of Clinical Hematology. And he will talk about beyond HLA, optimizing non-HLA variables. So we know that age of the donor is an important factor for outcome of transplantation. We can see here it's with sibling and unrelated. And we know that for every 10-year increment in donor age, there is 5.5% increase in the hazard ratio for overall mortality. And age should be considered when selecting for comparable HLA made volunteer donors. But this is also true, the age of the donor impacts the outcome of haploidentical transplant, and you can see here two studies. One is from Acute Leukemia Working Party, and the other is by Dezam et al. And you can see that if the donor is below 40 or 45, results are better, and this is usually the cutoff point. Now, HLA is important. Also in the PTCY area, there is controversy about this, but I will show you some data that is important even with PTCY, and there is crosstalk between age and HLA factor. So Professor Fuches published a few years ago that matching in the B leader is important for the outcome of haploidentical transplant, and you can see here in this recent paper that if you have a young haplo donor with a B leader match, then the results are better than sibling transplantation. But if you have younger haplo donor with B leader mismatch, then the results are not better. So there is a crosstalk between age and factor of the HLA. Now we know that with increasing age, we have increased chance for the clonal hemopoietic of indeterminate potential, the chip, but not all chips are bad, and this is the controversial studies that were published in the Journal of Clinical Oncology a few years ago, that if you have a chip with DNMT3A, then it's beneficial because you may have lower relapse rate because you increase the chronic GVHD. So what about kidship? You can see here two papers that parental donor and others shows that especially maternal donor is not beneficial in haploidentical transplant. But we again in the acute leukemia look on this and fail to show that the impact of a donor kinship. What about female donor to male patient? We know that it's increased the chronic GVHD because they're exposed to multiple antigen during the pregnancy, and this is true also for haplo. And then for the ABO mismatch, if you have major ABO mismatch or bidirectional ABO mismatch, especially with bone marrow graft, your survival is lower. Now, donor-specific antibody is extremely, or maybe the most important factor in the donor of haploidentical transplant, because if you have more than 10,000 mean fluorescent intensity, you have to change usually the donor. What about KIR? With KIR, we have controversial result. The Baltimore data shows that KIR mismatch is beneficial, while the Chinese data shows that it is determinantal. And we at the Acute Leukemia Working Party also showed negative effect of the KIR mismatch on outcome, especially when you have a peripheral blood grafts. So a recent paper, very recent, showed that three quite simple factors in the haplodonor are the most important one, and this is the age about 37, peripheral blood stem cell graft, and female to male. And if you have these three factors, you are doing bad. And these are the conclusions. So if we move to another HLA paper that shows the impact of HLA in PTCY haplo, and this is a fascinating paper by Katerina Fleischur, that is an international leader, really pioneer in the field, and this is oral presentation 692, and the title is Immunopeptidome Divergence Between Mismatch HLA Haplotypes and Survival After Haploidentical Transplantation. So we know that there is HLA polymorphism in the peptide binding group, and this is the peptide binding motif. The peptide repertoire is the immunopeptidome, and this is detect the effect T-cell alloreactivity. And every HLA allele mismatch can be either peptide binding motif mismatch or a peptide binding motif match. And it was shown that in mismatch unrelated transplantation, if you have peptide binding motif in the GVH direction mismatch, then you have inferior results, as you can see here, with the blue curve and dash curve. So the aim of the current study was to see association between the cumulative number of peptide binding motif GVHD mismatches on the unshared haplotype and outcome of haploidentical transplantation. So you can see they had 2,869 HLA allele classified into 22 peptide binding motif groups, and you see the distribution of the peptide binding motif in the various HLA loci. And so you can have between 0 to 4 peptide binding motif mismatch in the GVHD direction, and the reference was 8 out of 8 mild with PTCY. And you can see here the patient characteristic. So if you have one peptide binding motif in the GVHD direction mismatch, then the results are worse than the reference 8 of the 8 bad, but they are also worse than if you have more than one peptide binding motif mismatch. And this is because for effective GVL effect, you need more than one peptide binding motif mismatch in the GVHD direction. And as you can see here, indeed, if you have one peptide binding motif mismatch in the GVHD direction, you have higher relapse rate than if you have several of them, and higher than the 8 of 8 MAD with PTCY. So this is also affecting leukemia-free survival. So again, the same like the overall survival, it's significant, but no effect on acute GVHD, treatment-related mortality, or GRFS. And so this new data can be potentially innovative approach to HLA-based selection of haplodonors and to the prediction of immunologic pressure on leukemia according to peptide binding motif status. Now, Yola Briost from Saint Anthony again look on age and various donors in the patient with ALL, and this was oral presentation 508. So in patient with ALL above the age of 45, she compared young haplo and young haplo donor. You remember for cutting age is 40, 2 old sibling donor 50 years or older. And these are the patient characteristics, And to cut the story short, if you have young haplo in red, you have lower relapse rate, but higher non-relapse mortality. And at the end of the day, the leukemia-free survival and overall survival are the same, and the GVHD in multivariant analysis is lower with young haplo. So the conclusion is that young haplo-identical donor seems to be a valid option compared to old sibling for patients over the age of 45 years undergoing transplantation from ALL and CR1. So in secondary AML, we compared haplo donor to sibling or unrelated donor, and this is oral presentation 505. And we had overall 3,862 transplant, 643 haplo, 715 sibling, and 2,504 unrelated. And you can see here the univariant analysis, and the best results, as I will show you, is with the sibling transplantation with 2-year overall survival of 58%, 2-year leukemia-free survival of 50%, 2-year GRFS of 40%, and non-relapse mortality is 10% compared to 26% with haplo because of lower acute and severe acute GVHD, better engraftment, while the relapse rate is double than haplo, 40% compared to 22%. And if we look now on the multivariant analysis, haplo versus sibling, so lower relapse with haplo, but higher non-relapse mortality. Also, higher non-relapse mortality with haplo compared to unrelated transplantation. We have better overall survival with sibling transplant, lower acute GVHD, grade 2 to 4, and severe acute GVHD, and better engraftment with sibling transplantation. And if we look now on the curves and the multivariant analysis, you can see better overall survival with the sibling transplantation, reduced relapse in the haplo, and higher non-relapse mortality, and lower acute GVHD and severe GVHD with the light blue curves with a sibling transplantation. So we conclude that in the absence of sibling transplant, both haplo and MAD are potential alternative, but still sibling is the best donor for secondary AML. So very important study with somewhat surprising results are the BMT CTN 1702 study presented by Stephanie Lee, and this is oral presentation 1695. And what they did, they defined, they look on searches of patients, and patients that have in the registry more than 2 potential MAD in the donor registry MADs, they called them MAD very likely, and the chance for finding a donor in this group was more than 90% of finding a MAD, and they expected that 40 to 50% of this patient will go transplantation, and in 90% of them it will be MAD. On the other side, there is MAD very unlikely, so this is patient with 10 potential MAD donor in the initial shares, and here the chance to find a match, unrelated donor, is less than 10%, and they expected that 60 to 70% of this patient will go transplantation, and the donor here will be 70% haplo and 15 cord-blood and 15% mismatch, and they compared these two, the 2-year overall survival of these two groups. So these are the patient, this is the number of the patients, 1,751, the various disease, and you can see that the expected figures are similar to the observed figures. And at the end of the day, the overall survival of the patient who is very likely to find a match and very unlikely to find a match is exactly the same. And this is true also for the relapse, disease-free survival, non-relapse mortality, no difference in these two groups, very likely or very unlikely to find a match. And also in the acute GVHD and chronic GVHD, exactly the same. So this is very important study. And the conclusion was that using the donor selection strategy that I described, there was no difference in survival for patients very likely versus very unlikely to find an 8 out of 8 MAD, and patients very unlikely to find a MAD should proceed to transplant using the best available alternative donor, usually haplo, rather than delaying the transplant because you try to find a matched donor. And this is a very, I think, important message to all of us during daily practice. Now, what about the interrelation between GVHD prophylaxis and the donor? So, Georgia Battiplaglia from Italy did a study in which she compared mismatch MAD 9 out of 10 with PTCY to match with ATG. She had 5,647 match with ATG unrelated versus 188 mismatch PTCY. And because the group were different, they did per match analysis 1 to 3, so 180 mismatch MAD with PTCY and 538. So the question is, can PTCY overcome the mismatching? And the answer is yes, because you can see in the curves. So all grade acute GVHD, all grade chronic GVHD, relapse rate, non-relapse mortality, 2-year leukemia-free survival, and 2-year overall survival, and the composite endpoints were exactly the same. So PTCY can overcome the mismatch, and the conclusion is that when a MAD is not rapidly available, choosing mismatch unrelated donor and using PTCY as GVHD prophylaxis should be considered. So if we just give 2 studies that are not in malignant, this is in severe aplastic anemia, a very big cohort of patients, 3,646, and this is from the severe aplastic anemia working party of the EBMT, and this is oral presentation 595. Again, they look on age and the donors and the year of transplant. So, for instance, they have 20% of the transplant in patient age above 40, which was once the cutting edge for allowing transplant in severe aplastic anemia. As for the donors, they had 40 sibling percent and 40% unrelated, but you see that there is already 5% of haplo in the registry and 11% mismatch transplant. And then for the years, they compare 2011 to 2015 to the period of 2016 to 2020. So first of all, the results of transplant are improving. So better results in the period of 2016 to 2020 compared to 2011 to 2015. And now if we look on the age of the donor, so if you have a young old donor below the age of 18, you are doing significantly better. Lesser result in the age above 60, but not significant. And this is also true for disease-free survival and GRFS. This is the whole cohort. You can see that it's confirmed by multivariant analysis. But now if you look on sibling transplant, so young donor below the 18 is beneficial, but a donor above the age of 60, here it's significantly with inferior results. If you move to MAD, now a young donor below 18 is better, but here donors above the age of 50 already significantly inferior results. So it's not 60, but 50 for the donor. If we look to mismatch unrelated, is quite similar, but now if we move to haplo, you can see that here a donor that is above the age of 40 is already significantly inferior outcome. So there is an interplay between the type of donor and the type of transplantation, and we saw a few studies that in haplo, it's about 40, 37, 40. And so the age effect remains significant within each donor type, but for a safe transplant, which was defined as 3-year overall survival more than 70%, the age might be set for 60 for sibling, 50 for unrelated, and no more than 40 for mismatch unrelated or haplo. Now, one study on cord blood, although we know it's going down, but it's important because it's long follow-up, and we need long follow-up studies in transplant, every other field in medicine as well. And this is oral presentation 596, and this is multi-center study from France, and this is the EPCOD study, so cord blood transplantation in aplastic anemia, and the study was performed between 2011-2015 and 26 patients. And they already reported in 2018 a very nice overall survival 1 year of 88.5%, but this is short follow-up. Amazingly, 8 years follow-up, the 8-year overall survival is exactly the same, 90%, so very impressive. This is cord blood for severe aplastic anemia. All prior or chronic GVHD no longer active, and immunosuppression was stopped. And as for the long-term toxicities, there are 2 patients with cardiovascular, MI, and other endocrine. So 4 patients with osteonecrosis and 6 with endocrine disorder. Only 1 patient with secondary malignancies, that's a big issue these days. 1 patient with immune-mediated thrombocytopenia, 2 infection, and only no patient with PTLD. Immune reconstitution for the long run is perfect, coming normal, and excellent long-term overall survival. So there is maybe a place in cord blood, short, very small group of patients, but very long follow-up, and this is impressive. So we are, deciding today about the transplantation according to the mutation risk, next generation sequencing, and we have the new ALN 2022. And Professor Ali Bajarbachi from the American University of Beirut challenged the new adverse level according to ALN 2022, and this is oral presentation 692. So the changes for the adverse risk cytogenetic in ALN 2022 is that the translocation 3Q and translocation 816 is high risk, and hyperdiploid that are presently omitted from the complex karyotype classification. So overall, 1,735 patients, 67 de novo ML, age between 18 to 76. You can see 10 groups. We cannot go all over them, but group 1, for instance, is monosomy 5-7 or deletion 5 without monosomy 17 or 17p. Group 2 is monosomy 17 or 17p. Group 3 is complex karyotype, non-monosomal karyotype. And group 4 is 11q23 without other adverse structural abnormalities. And when they did a multiple correspondence analysis, we have category 1, monosomia 5, 7, and 17. Category 2, complex karyotype 17p abnormality and deletion 5. Category 3, the 3q26, 6, 9, and 922. And the 4 is 11q23 and 816. And so overall, the 2-year overall survival is close to 50%. Relapse rate is high, high-risk leukemia, no wonder, 43%. And now if you look on the curve, so the worst result in green is for monomosomia 17p, not so surprising. And the second worst is for group 1, monosomia 5, 7, or deletion 15. And then for the group 3, complex karyotype without monokaryotype, the group 4 with the 11q23 and group 5 with complex karyotype and monokaryotype in red, there is no difference. These are the curves for the other groups. For sake of time, we cannot go to each group. But at the end of the day, in multivariant analysis, compared to the group of complex karyotype without additional adverse abnormalities, the leukemia-free survival and overall survival was inferior for group 2, monosomia 17 and 17p, group 1, monosomia 5, 7 or deletion 5q, and group 10 translocation 816, and it was better for a patient with 922 translocation. And again, in a graphic way, the worst results for 1717P, second worst monosomia 57 and deletion 5 and 816, and the best result for monosomal not 5717, translocation 92 and 69. So the conclusion in this large real-world study is that very poor outcome of allografted AML patient with monosomia 17 or 17P, poor outcome for those with monosomia 5, monosomia 7, deletion 5q, abnormality 3, Q, and 816, and good or very good outcome for most other categories, including complex karyotype, without monokaryotype other than 5, 7, and 17. And this may indicate that allotransplantation can overcome the poor outcome of this ALN 2022 adverse genetic, and this is extremely important. Now we are transplanting more and more elderly patients, and just to remind you that the median age of a patient of AML is 72, so important topic. In most of the transplant center, most of the patient now is above the age of 65. And geriatric assessment is coming in, is extremely important, and the Sloan Kettering group with Sergio Girald evaluate the geriatric assessment of their patient, and if the patient is fit, then they gave myeloablative conditioning, and no wonder that in elderly patients, few of the patients are fit, and so only 8 patients receive myeloablative conditioning. And if the patient is less fit, they received reduced intensity of non-myeloablative conditioning, and this is 24 patients. And the hypothesis or primary endpoint was that they will be able, by the geriatric assessment, adapted approach, conditioning, they will be able to reduce the non-relapse mortality from 25% to 10%. And so this is 32, a group of 32 patients, upper age 80, unbelievable, median age 70, almost unbelievable. And this is the baseline geriatric impairment, and the study is impressive. Primary endpoint, 1 year non-relapse mortality in patient of 70. Going allogeneic transplant is only 6%, so this is the level, almost a bit more than autologous transplant in lymphoma or myeloma, maybe double, but really so impressive. Progression-free survival at 2 years, 53%, overall survival 68%, and they did impact of longitudinal geriatric co-management, and it's stable, so up to 1 year post-transplantation. So again, very important study with the conclusion that a geriatric-driven risk-adapted geriatric co-management strategy may help reduce treatment-related mortality and morbidity and help to prevent functional decline and enhance recovery for older patients and should become a common practice. Now, what about novel conditioning? So this is the important study by Professor Popat for MD Anderson. He is pioneer in the field, oral presentation 506, and he developed with Professor Bore Anderson the approach to give the IV busulfan very early, day minus 22, fractionated busulfan together with fludarabine, but now they add cladribine, thiopeta, and venetoclax to what they call cladilac conditioning. And so this is the protocol. You can see very early IV busulfan, day minus 22, before the graft, and fractionated busulfan according to the area under the curve with fludarabine, but now adding thiotepa, cladribine, and venetoclax with post-transplant cyclophosphamide post-transplantation. So this is the group of patients. You can see that we did then analysis of low, younger or older than 60, various donors, as you can see, matched sibling, MAD, mismatch, and haplo, but all of them with PTCY. The progression-free survival at 2 years, 61%, and the overall survival is about 65%. Relapse rate is at 2 years, 16%, and non-relapse mortality 22.4%. Now, no difference impressive between patient below and above of the age of 60. And also reasonable acute GVHD, 36.7% at day 100, severe 14.3%, and chronic severe GVHD or moderate low 8%. These are the toxicity and cause of death. And of course, P53 is always bad, but so with this protocol, again, some better not to have P53. So the novel regimen with myeloablative fractionated busulfan, fludarabine, cladribine, tiotepa, and venetoclax, so 5 drugs, cladilac, appears to be safe and appears to reduce relapse rate without increasing non-relapse mortality in a cohort of very high-risk patients with AML and MDS. So innovative protocol. If we continue with the conditioning in one of the few lymphoma that remained indicated for allogeneic transplantation, and this is mature T-cell lymphoma, and a study from City of Hope and Mayo Clinic. This is 75 patients, and what they did here, they compared myeloablative conditioning to the reduced intensity conditioning, and also yes or no TBI, and also myeloablative versus non-myeloablative TBI. So you can see here the 3-year progression-free survival, and if you receive myeloablative conditioning, you're doing worse than non-myeloablative conditioning. If you receive TBI, you're doing worse, but if you receive myeloablative TBI, you're doing really bad. So a 3-year progression-free survival of 18% compared to 86 with now no myeloablative TBI. This is similar in 3-year overall survival. So you can see lower result with myeloablative, with TBI, and again, myeloablative TBI is 33% compared to 100% with no myeloablative TBI, and the 3-year relapse overall is 15%, and you can see here even the relapse is higher with myeloablative conditioning, higher with TBI, and with myeloablative TBI is 49% compared to 14% no myeloablative TBI, and for the non-relapse mortality, it's 50% with myeloablative versus 14, and with myeloablative TBI is 58% compared to 0 without it. So the conclusion is one important one: the allogeneic transplantation remain a curative option in patients with mature T-cell lymphoma and can overcome the poor prognosis associated with relapse refractory disease. Still very little experience with CAR in this category, although there is CD7 CAR, and TBI containing conditioning regimen were associated with worse progression-free survival or non-relapse mortality. So rare disease, but important for transplant, and TBI is out. Now a lot of progress in recent years in GVHD. So few studies for GVHD, and I will start with this one. So this is multi-omic immune profiling of graft versus host disease. This is from the group of Ran Reshef from Colombia, and this is oral presentation 381, and it's multi-omic immune profiling of GVHD. And so this is cutting-edge technology, temporal dynamics, immune profiling, and spatial interaction. And so they looked on 20 patients with various grades of GVHD, did MLR from peripheral blood sequentially post-transplant, and again, temporal T-cell clonal dynamics of various techniques, T-cell clonotype analysis, T-cell trajectory analysis, and spatial immune host interaction. Very sophisticated. There is higher frequency of alloreactive T cells that are associated with severe GVHD. Moreover, severe GVHD patients show, as you can see, increased alloreactive T cell clones and more diverse alloreactive T cell receptor repertoire. And if you look on the dynamic of the clone, so you can see when you have no GVHDs, there is decreasing. When there is mild GVHD, it's transient, and it's much more complex, as you can see in patients with severe GVHD. Now they also did the single cell and they compared the various immunological subset of post-transplant patient and normal donor, and you can see that it's totally different. And in patients with severe GVHD, as you can see, there is enrichment and clonal expansion of CD8 effector and proliferative T cell in severe GVHD patient, and moreover in spatial technique in the creeps in the GI tract, there is increase in T cell infiltration and CD8 effector in the creep lost in the patient with severe GVHD. And the conclusion is that increase in alloreactive T cell frequency in severe GVHD. Severe GVHD is enriched for CD8 effector proliferating T cell with enhanced cytotoxicity, and increase in T cell infiltration and CD8 effector cell surrounding creep loss. So we are understanding better our severe GVHD patient, which is unmet need. So several studies, important study of GVHD. First, this study again from the CIBMTR, BMT, CTN, and this is subgroup analysis of the so important study 17 of 3 and oral presentation 1042. And as you remember, the 1703 compared PTCY with tacrolimus and MMF to tacrolimus and methotrexate, and it shows the improvement in GVHD and reduce in severe acute GVHD and chronic GVHD with the PTCY. But now they looked on patient, and this is the original curves, but now they look on patient above the age of 70 because we are transplanting elderly patient and because there is correlation between the age of GVHD. So much difficult, more difficult group of patients, 96 patients, 43 in the PTCY arm and 53 in the control. And the results are holding. So for instance, GRFS is better with PTCY in patients above the age of 70. The overall survival is better with PTCY in this subgroup of patients. There is no difference in the GVHD events. The GVHD-free survival and immunosuppression-free survival are better with PTCY. There is no more infection and no more cardiotoxicity in spite of the PTCY, and the transplant-related mortality is better with PTCY, lower, and no difference in relapse. So the PTCY is beneficial and better than the conventional tacrolimus methotrexate, including in patients above the age of 70. Very important study, encouraging study. Now, we know that PTCY have some cardiotoxicity, and this is a paper from the group of Professor Hamadani. And so they ask if they can reduce the dose of PTCY, but replace it with ruxolitinib. So this is the study. They reduced the dose of the post-transplant cytoxan by half from 52 days to 25 days, but MMF tacrolimus, but they add from day 30 to 6 or 60 to day 360 ruxolitinib in the regular dose, 5 milligram twice a day, in patients above the age of 60, so more cardiotoxicity in this group of patients. 24 patients, you can have you can see here their characteristic, and very impressively, 0 non-relapse mortality. Nice engraftment, the usual one, day 13 for ANC, day 12 for platelet. Very low incidence of grade 2 to 4 acute GVHD, 8.3%. Very low incidence of chronic GVHD, 11%. Relapse rate is 22%. And the very impressive 1 year overall survival of 88%. Of course, this is short follow-up, and the conclusion that maybe you can substitute some of the post-transplant type by ruxolitinib. And if we continue with ruxolitinib, very big, important study from China, well randomized design study, moving the ruxolitinib up front. So this is multi-center two-arm study in which they compare ruxolitinib, cyclosporin A, and methotrexate to the control MMF, cyclosporin, and methotrexate, 103 patients in each group. And so this is the patient characteristic. They have here the age of 42 compared to 39. And if we look now on the primary endpoint, so 100-day grade 2 to 4 GVHD, 37% in the control group to 8% in the ruxolitinib group. If they look on day 180, 2 to 4 GVHD, it reduced from 39% in the control to about 13% with ruxolitinib. If we look on the chronic GVHD, so moderate to severe chronic GVHD is reduced from about 20% in the control arm to only 3.3% with the ruxolitinib arm. Engraftment with platelet is the same. Maybe with myeloid, engraftment is a bit slower with the ruxolitinib arm. The relapse rate is the same, but the non-relapse mortality is reduced. At the end of the day, overall survival is the same, 3 overall survival of 86, very nice to 86%. But the GRFS is improved in the ruxolitinib arm. So moving the ruxolitinib low dose up front may be beneficial with reducing the grade 2 to 4 GVHD and lower incidence of severe and moderate chronic GVHD, reduce non-relapse mortality, and improve in the GRFS. So the other complication of transplant, unmet need, is relapse. And this is important study, real-world study with FLT3 inhibitor post the transplant. So this is 440 patient study. You can see here the demographic. You can see that they used all the FLT inhibitor available. 171 patients received FLT inhibition maintenance, and 269 did not receive. And this is they also look on the VAF of the FLT3 below or above 0.5 and the patient characteristics, so they are no different. And at the end of the day, the overall survival, relapse-free survival is better if you receive FLT3 inhibitor maintenance because you reduce the relapse rate. And so FLT3 inhibition maintenance improve overall survival by 89%, very impressive, and relapse-free survival by 81% because they reduce the relapse rate by 78%. The poor prognostic factor are FLT3 VAF above 50 and high comorbidity. And so interestingly, no difference between sorafenib and glitteritinib. And about the VAF, so in patients that received FLT3 inhibitors, it works for both high VAF and low VAF, but still results are better in patients with low VAF, while in patients that did not receive the FLT inhibitor, whether they have VAF above 50 or below 50, they are doing bad. And so FLT3 maintenance in FLT3 ITD positive AML patient is extremely beneficial, very important message. So, we are running up to the end of our, presentation, but there was many other abstracts that I could not address, and I listed 5 here that you are invited to go in. It's worthwhile. One of them is from the Spanish group with Jordi Steve, and the title was Validation of a Very Poor Risk Adverse Plus in AML Patient Undergoing Allogeneic Hematopoietic Cell Transplantation. As this is similar to the Professor Bazarbachi studies that I show you. There are 2 ORCA T studies, so are we going to again to stem cell manipulation or graft manipulation? One was preliminary safety and efficacy of myeloablative ORCA-Q and with no GVHD prophylaxis, and the other one was observational comparison of overall survival between phase 1B ORCA and registry. and 3 studies from the lab of Katie Wu, and very important and sophisticated cutting edge with the most modern technique. One, Professor Katie Wu by herself present in a session with the title was Host Factor Driving Anti-Leukemia Immunotherapy Outcome, and the title of her talk was Immune Microenvironment and GVL Effect. So GVL important, very important transplant. Another oral from her group is 926 on GVL was leukemia evolution and resistance to graft versus leukemia response revealed by mitochondrial DNA mutation. Very hot topics. And the third abstract, oral 102, this is GVHD again. So acute GVHD of the gut is associated with minor histocompatibility antigen cross-reactive against gut-topic vital epitopes. So I will end with acknowledgement of all my colleagues and friends that were kind enough to give me a slide of their unpublished presentation, so it's not trivial, that were presented at ASH for this post-ASH webinar on behalf of the International Academy of Clinical Hematology, concentrate on transplantation, and I cut my talk in order to be in time. So thank you very much.
Thank you so much, Professor Nagler. Superb review, complete transplantation review of ASH meeting. So One Place Shopping Center, and this recorded webinar will be available on ISCH website in about 48 hours. So you can go there, review there anytime, any day, anytime. And again, as I said last time, in the past, I used to sign up for all the journals, Blood, New England Journal, Lancet. Nowadays, I don't. Whenever I have a time to review something, I just go to the ISCH website for all heme malignancy, transplantation, and CAR-T education. Thank you, Professor, for excellent review. Now we have lots of questions. So I'm going to read the question in the order I received. So let's start with lots of questions about conditioning regimen, donor selections, and post-transplant relapse management, and how do we do transplant in relapse. So let me start with first question. Is it important to measure DSA in every donor prior to allo transplantation? Which donor would you perform DSA on?
So it's becoming very important factor. I mean, it's more important in alternative donor transplantation, so mismatch transplant, haplotransplant, and cord blood transplantation. Now, if you have high mean fluorescent intensity above 10,000, if you can, the best is to change a donor. But there are also, we publish a big review on it in BMT, which you are the editor, Professor Bittin, a few years ago, with Professor Chiura, previously in MD Anderson, and now I guess in Ohio, yeah. And but there are protocols to desensitize the donor. It's sometimes successful. Of course, there were attempts with daratumumab, and now there is attempt even with CAR T cells. There is an abstract in ASH on 5 patients from China that tried to give a CAR T cells, BCMA special with CD19 in order to reduce it, but usually there are attempt desensitization protocols. In our hands, it's not easy to reduce the level of DSA if you have high level. Yes.
Thank you. Thank you for detailed response, Professor Nagler. So next question is on conditioning regimen. What is the best conditioning regimen for myeloid malignancy in fit patient and unfit patient, irrespective of donor, whether it's unrelated donor, related donor, or haplodonor?
So I don't know if there is such a best conditioning, because there are many conditioning, and I mean, each transplant center has his own philosophy, own strategy, own history, so it's hard to say. We all know that the traditional conditioning regimen was Bussai and TBI cyclophosphamide. At least in many centers and in our center, TBI was omitted from the AML, but in Germany, most of the transplants are still in AML, are doing with TBI, and there are new data that, including published from acute leukemia, and about TBI and fludarabine, different dose, 800 compared to 1200, different result in AML, ALL. In ALL, most of the centers are using TBI, but transplant in ALL are going down because of the CARB, blinatumomab, inotuzumab. In MD Anderson, they hardly do transplant for adult ALL, and because of the CARs in the high risk mutation one there. And so we are using fludarabine busulfan. According to the data, this is fludarabine replacing busulfan. This is data of a JITMO trial for Alexandro Rabandi. You can reduce the transplant-related mortality without paying the price of higher relapse, and there is 10 years follow-up just published in blood cancer research. Of course, TBF is an attractive protocol in Europe. We are using it for haplo, and you have myeloablative TBF according to the dose of Teotepa and reduced intensity. So I would say that flu-bu is a protocol that we are using. Of course, there is the melphalan flu using pioneered in MD Anderson. We are not using it so much. And TBI we are using only for ALL, but I would say that there is no such best protocol for myeloablative or reduced intensity. There are several trials, and again, the acute leukemia published a new score, the conditioning intensity score by Alexandros Parionitis, and this score, very nicely divide the patient between high, intermediate, and low dose, and some of the centers are starting to use this new score in order to calibrate the condition.
Thank you, sir. So now, next question I have merged together. There are several questions about management of post-transplant, either maintenance or relapse. So let's start with the maintenance. So if patient has no targetable mutation, when do you consider post-transplant maintenance, and which agent do you consider post-transplant maintenance in myeloid malignancy?
So this is very important question. Unfortunately, we don't have recommendation, and we don't have almost no approved drug. But I would say that every patient with high risk AML that you can give maintenance therapy should get maintenance therapy. Not everybody agree with it, but this is our philosophy. Of course, you published, Professor Bipin, about monitoring of MRD, and exactly, DLI and what maintenance therapy and how to do it. So several papers you pioneered on this. And so if there is targeted therapy, unfortunately enough, we have IDH1, IGH2, we have FLT3, and things are coming. We are using those. In patients, we are using sorafenib, but in patients that have no mutation, we usually use Vidaza, and sometimes we combine with DLI, but not sure that you need for Vidaza DLI. And we try to adapt it to the MRD, and this is a major question and controversies that we discuss in various meetings, if you have to give to all FLT3 or just according to the MRD. But I would say the most popular drugs you need to give to high risk is Vidaza and sorafenib, but in place like, rich, and like in the States, I'm sure that they are using glitteritinib and other, and there is even studies from Boston from Harvard, in which they incorporated venetoclax upfront to the conditioning, but also to the maintenance. As these are and these updated data were also in abstract and even published recently in Blood Advance. So venetoclax is becoming an important drug, and I'm sure people will use it post-transplant as well.
Now, last question. We are almost end of the timing. Last question is on refractory disease. Do you consider refractory acute myeloid leukemia or MDS with excess blast for transplantation? And if yes, when do you consider? And what is the outcome?
Okay, so this is becoming hot topic and very controversial and philosophic question, and we can even push it to the corner and talk about P53. So do you transplant a P53 patient? Do you refractory ML? So no question about that. The result of transplantation in refractory AML and moreover in P53 are worse than if you don't have this refractory or P53. However, as you have very little to offer to these patients. You cannot cure them without transplantation. And sometimes you are lucky, and I would say that you can reach 20% long-term disease-free survival in this patient, and you may try to intensify or to give maintenance post-transplantation. So this is philosophical question. In our place, we are transplanting this patient. Sometimes it's even because of pressure of the patients, of the family, of the colleague. All of us can say theoretically not to transplant, but then high-rank VIP call you, he's my cousin, he's my relative, please, we know the results are not great, but please do it, So this, is basically our philosophy, but I agree that we should improve, and hopefully with new strategies, hopefully new compounds and so on, we will improve our results. Unfortunately, immunotherapy is in its infancy in myeloid malignancies, in myelofibrosis, MDS, and AML, and so till we have a CD19 CAR equivalent in AML, I think the transplant are to stay.
Professor Nagler, thank you so much for top-class review of ASH 2024 transplantation summaries. Again, thank you so much, and thank you for our attendees. They are still here right now, almost same numbers like when we started, actually. And again, those who are not able to attend this webinar fully, recorded webinar will be on site, online in about 48 hours. Thank you so much. Good night. Thank you so much, Professor Nagler, again.
Thank you, Professor Bitten. ICH. Thanks our audience. Good night, good morning. Continue your clinics. Bye-bye.
Thank you.